And welcome to AWHONN Insights, the home for candid nursing conversations where we discuss what you need to know with nurse experts and colleagues who provide reproductive health care. I'm Bria Anopise, Associate Director of Publications at AWHONN, a Lamaze certified childbirth educator and mom of three. My pronouns are she, her. Today, it's my privilege to welcome an amazing AWHONN member who's also a co-host of this podcast, Jennifer Peterman, a clinical practice leader on postpartum and well baby units, a lactation consultant, and a four. Pronouns are she. We're excited to welcome our special guest, obstetric anesthesiologist, Dr. Tracey Vogel. Pronouns she, her. She speaks nationally and internationally about birth trauma, the need for trauma awareness, and promote centers of excellence in providing trauma-informed care for patients. Continuing our conversation to highlight Maternal Mental Health Month, today we're focusing on Dr. Vogel's expertise in empowering patients to share their stories and training clinicians in perinatal trauma-informed care. Jennifer, I'll now turn the podcast over to you.
Thank you, Bria. Welcome, Dr. Vogel. So, Dr. Vogel, you're the director of a perinatal trauma-informed care clinic. The definition of trauma is exposure to an actual or perceived threat or violence. But what exactly is trauma-informed care, and why is it important in the perinatal setting?
Well, when we think about trauma-informed care and trying to define it, I think we have to start with something that's maybe a little more generalized as opposed to some specific definitions. It's really a shift in the paradigm of how we think about individuals, how we approach them in our care. I mean, one of the things that's often quoted is shifting from a what happened, or instead of what happened to you, it's what's wrong with you. That's where we start. What's wrong with you? And it's that judgment that comes out with that. Instead, it's trauma-informed care helps us to shift from that into a what happened to you. And again, trying to pull back from that judgment and trying to understand that the past is influencing what's happening to them in the current. Another paradigm shift, the way I think of it, especially with patient care, is going from, this is what we're doing to you today. We are going to do this cervical exam. We are going to put this epidural in. We are going to do this. Instead, it's a shift to what can we do together to get to some mutually agreeable goal that allows us to respect, acknowledge, understand your cultural context. This is very different. It's not this, I know everything and I'm going to tell you what's happening, but it's, hey, let's involve you in the conversation too, and taking into account where they come from. Another way of thinking about it, which I really love, is really the ultimate here, is to shift from thinking about a patient's behaviors, especially if they come from trauma and they are acutely triggered in a circumstance, but shifting from seeing a patient as problematic, which we all hear that term, as difficult patient, problematic patient. Instead of seeing them as problematic, we shift to seeing them as symptomatic. Like, here's an example. If I said a nurse went into a patient's room and the patient's in there a little bit combative, saying things that aren't appropriate, jittery, things like that. And the nurse walks out and they tell the nurse, I know she feels the patient's difficult, but they tell the nurse, your patient's glucose is 35. Nurse might say, oh, okay, there's a reason for why this patient has this behaviors. The treatment is this, it's glucose. And then most of the time, the provider doesn't take that personally, doesn't take that to heart, those behaviors. It's the same thing with trauma. Those behaviors have a cause and it has a certain intervention. But I would love to see the provider walk away from it and not feel that they're internalizing that conflict or adversarial care. And that's another aspect of trauma-informed care. I think it's also important to think about trauma-informed care as a continuum. It's not something that you check the box and say, I did my lecture, I'm now a trauma-informed provider. It's not. And I know, Jennifer, you came to our full day training. And even after that, providers aren't necessarily fully trained, but it's a change in culture. And so if we think about it, you start with trauma awareness. That's more of a cognitive part of it, where providers start by learning what is trauma? What does trauma look like in survivors? How does it present in labor and delivery? What are the interventions that we need to do? What are the consequences of a traumatic, all those, for example, cognitive things. The next phase is really trauma sensitivity. So you go from trauma awareness to trauma sensitivity. That's when you are starting to shift your lens. You now can appreciate what that person how that person lived their lives before, where they've come from, how that's impacting them. You don't judge as much. It's like you lose the judgment and you understand. That's the sensitivity. The next phase is trauma-informed practices, where you are then changing your behaviors, changing policies, protocols. You're moving into that. I'm doing this differently because the patient needs it. Then the fourth stage is really healing-centered. And that's where systems should be striving to be healing-centered. And that's what we're trying to do in our state of Pennsylvania, is move all systems to that. But that's where we're not only treating patients in the moment, but we are looking towards how can they go out and actually heal and have post-traumatic growth from something that they've endured, whether in our care or even before that. So that is what trauma-informed care really embodies with all of that.
That's a great explanation. It's a continuum. It's not one thing. I like how you put that into words. And I know you're an anesthesiologist. So how did you get involved in this work? Far from anesthesia.
Yeah, great question. A lot of people ask me, how did you end up here? Like, what is this? And I certainly didn't start off thinking, oh, I'm going to be a trauma-informed care specialist. No, I've always enjoyed obstetric anesthesiology, and I knew that early on. I did my fellowship in obstetric anesthesia. About 12 or 13 years ago now, I decided that I only wanted to work in that space. And I did not want to work any longer in the just general population as well. So I shifted and found a position that would let me do exclusively obstetric anesthesia, which is where I am now in Pittsburgh. And that was a real turning point for me, because I spent 4 days a week working clinically on the labor and delivery unit every day. And then the fifth day was a lot of non-clinical work and education. And I started to see things differently. You just start to see trends when you are there every day and not just coming once every couple of days or on the weekends. And at the same time, my children who are in middle school and high school had some different projects. My son was reading Missoula, which is a Jon Krakauer novel about rape on college campuses. So there was that discussion in the house. And my daughter was watching 13 Reasons Why, which was about mental health issues and sexual assault for a young teenager. So all of that's happening. And then I was referred a patient with known PTSD. And at that point, I really didn't know what to do with that. That was out of my comfort zone. I had no training. But I was curious and I was compassionate. And she was the one that dictated her care and taught me a lot of what it was like to live with trauma and PTSD. And she's the one that said, you should maybe think about going to Pittsburgh Action Against Rape. It's our local rape crisis center, and get trained. I said, okay. So I decided I wanted to give back to my community. I wanted to volunteer, but I ended up going there and training. So 40 hours plus volunteer work and supervision. And it was a real aha moment for me, because now I had my first exposure to trauma, albeit a specific type of trauma. But what was it like for a survivor in the acute phase? And what does a survivor look like as an adult later on, or just years later on? So this gave me context for what I was seeing in labor and delivery. And not all of my patients, of course, were survivors of sexual trauma, but a lot of them had birth trauma, intimate partner violence, military sexual trauma. I mean, you name it. It's racial-based traumas. But I had tools now to bring back to the labor and delivery space and to start working through that. And then I, built into what was pre-existing. I had a high risk OB anesthesia clinic that I would see patients that had more physical issues like scoliosis or heart disease, lung disease, things like that. So I started to ask my colleagues, hey, why don't you send me patients that have PTSD, or if you know they've had birth trauma, send them to my clinic and I'll talk to them and we'll see about working out some plans. That's where it started. And then fast forward to 2020, I received a grant, and that's how I developed the infrastructure for my clinic that now exists. And we built it into Epic, referrals, marketing, all of that. So yeah, that's how I ended up here.
So it all came from listening to a patient who referred you. So
yes.
Yeah. So listening
yes.
to patients is how it all started.
Right? And yes. And I will also share in here just a little bit. There was also a grievance, because I want people to know that it came out of some challenging moments for me too, where I was forced again to listen and accept feedback from someone when I thought I understood what she wanted and I hadn't, and that's tough for a provider to realize I thought I was doing it all right and I wasn't, and I had a lot more to learn. So then that's when I realized listening and giving patients a voice is going to be one of my lifelong goals with this project. So,
and you're doing a great job with it.
I just want to say I really admire that so much. I like that you said you were curious and compassionate. That's huge. The compassionate part is everything.
Yeah, I think so. But also, I'd always felt like I was compassionate, but it was that extra bit of being willing to be vulnerable and to be humbled and to really sit with that, to know, okay, I'm going to listen to this patient, sit with it, and make change and see what we can do. Right?
Because compassion goes both ways, because you can be as compassionate, but if the other person doesn't feel it, then you're not compassionate. Right. So it has to be a give and take on both ways. Right. It's not something that I am. I'm compassionate with somebody, not in myself. So an important part of a nurse's role is being a patient advocate. Can you give us some examples how nurses advocate for their patients in a trauma-informed way, or how can bedside nurses take a trauma-informed approach for their patient?
So that question, we could spend a whole day here talking about all the ways that nurses work magic in their practices and can do things with trauma-informed things. To break this down, just to simplify it a little bit, I think we can think about 3 different categories. So from a cognitive perspective, like what are some of the knowledge-based things that a nurse could take, to thinking more of it from a technical aspect, and then even behavioral changes that a nurse could put into that. And I think about it in those senses because when we do simulations and we are facilitators, we think through these 3 different categories of skills that we want people to have. When we think about cognitive, I think some of the biggest things a nurse can do is to understand trauma and what it looks like. Number 1, get the lectures. Those you can pull offline. Learn, what does a survivor of trauma look like? What do acute stress responses look like? I will never forget a situation that I had with a patient, and this was before I had my clinic. So a nurse pulled me aside and said, Dr. Vogel, this patient is incredibly anxious about her cesarean delivery. She said it's much more than what you would normally see. She knew to let me know ahead of time, knew to pull me out. And this was a patient who, when I went to see her, her lips were purple. She was so vasoconstricted from fear, literally terror. And she had never had a chance to talk about this, but she had had pain during her previous cesarean delivery. And the nurse sensed something was wrong. So with that nurse together, she was able to help me to get her through the operating room experience, We minimized traffic through the room. We kept it calm and quiet. I, of course, did anesthesia things that could give her the confidence that something was working, give her the control to dictate how she wanted her anesthesia to go. But that nurse was pivotal in recognition, first of all, on what was happening. When we think about, let's say, behavioral types of interventions, I think about listening, as we talked about, listening skills, how important it is not to dismiss someone's concerns, whether that's about pain or whether they feel like they can't handle the messy sheets because they've had trauma and that's reminiscent. Maybe the nurse then uses open-ended questions and sits with that patient and says, it sounds like it's really distressing for you. Can you tell me more? What can I do to make you feel safe? Right? Asking open-ended questions, sitting down with the patient, not dismissing them, learning how to listen. And all the things that go with kindness, right, are all part of that behavioral modifications. When you talk about technical things, that can be as unique as everyone's individual trauma narrative. Everybody that I meet with in my clinic might have something different that they need. I had a patient once tell me, I need to keep my cough drop with me in the operating room. Okay. She didn't need to eat it, which would have been a little more of a concern, but just to have it in her hand was her comfort. Other people need to keep their significant others with them. Other people need medications. Some would like to be covered the whole time. So when it comes to what a nurse can do, they can do a lot. And not just advocating for their patients, but protecting privacy, making sure that people knock, announce themselves before they come into the room, putting signs on the door to protect them. They can hold their hands if necessary, right, in the operating room. They can ask permission before touching a patient. That's very important. All of those are more of under like the technical aspects of trauma-informed practices. They can also advocate at levels of policy change. I see the biggest drivers of so much change in our hospital systems are through the nurses. And you're a powerful group, and you can continue to advocate and make these changes. Some of them, if we need to make the policy change so that we're not advocating one patient at a time. For example, the use of arm restraints on an unsedated patient for cesarean delivery. Even one that has a little bit of sedation doesn't need arm restraints. It causes psychological harm. So that's an easy one to start with, and nurses can advocate to remove the arm straps if in those spaces. So just some examples there. Like I said, we could probably go on for a while, but
yes, I can think of 10 other ways that we could advocate for our patients in this way. But when I took your training, I found some of the patient stories quite impactful. On your website, The Empowerment Equation, I encourage all our listeners to go on and take a listen to some of those testimonials. But one that touched me was a patient hearing the words congratulations and how those words affected her. Can you share other words or phrases can affect a patient and the perinatal nurses should be mindful, like to maybe avoid or to be mindful when they're speaking to certain populations?
That's another one. We could do an entire hour on language that we choose, but there are some that are built into our vernacular, and they always come up when I think about language choice. One of my favorites, I think I mentioned already, is difficult or problematic patient, right? I often wonder, like, what does that mean? We say the patient is difficult. Dr. Vogel, go work with that person in room 3. She's difficult. I often interpret that as, I don't understand the patient. So therefore it is their fault. They're the difficult one. And I think honestly, if we ask the patient, they would feel the same way about the provider. They'd be saying, I don't understand them. They're the difficult one. Why don't they get it what I need? Right. So I think we need to rethink how we say things. Another one is non-compliance. And this just came up recently with my own mother. A quick example. She's 83 years old, and they sent her home with a Holter monitor with some instructions, but the instructions were given so quickly. It had to do with a lot of technology, which she is not good with and she's afraid of. And she's not recording as she should all the times when she has an event, which is what you do with a Holter monitor. And I thought to myself, okay, you're going to go back in and they're going to say non-compliant with this device. Because it's all one-sided. We say non-compliance. What do we really mean? We mean that person didn't listen to me, didn't follow what I told them to do. But then there's nothing else after that, right? Instead, I think we should be saying this patient was not able to follow our recommendations because, like in my mother's case, because she didn't understand the technology. The directions were not easy for her to understand. And we need to do this again, right? Or for our patients on labor and delivery, this patient could not follow our recommendations for insulin because she has a fear of needles. Her significant other took the car. She can't afford the medications. I mean, there are a lot of things. And you see how it balances out how we then might perceive that person. Because how we write about people becomes how we think about people, whether we say it or we write it, which then becomes how we interact with people. And they're doing a lot of research now into the use of stigmatizing language and how it alters how we perceive that person and how we then treat them. And another example of some languages, even just our built-in vernacular. What is the primary complaint? What's my favorite? Complaint. When we use the word complaining in any other circumstance, it's not a positive word most of the time, right? So if we say patient's complaining of pain, we start to think about it a little differently than if we said the patient's concerned because her pain score is now a 7 out of 10. Makes us think a little differently. I'm trying to think of some of the others. Patient claims is another good one. Patient claims to have done this or that. Let's step back.
What automatically infers that they're not telling the truth, right?
Right?
What a word.
We just build this in, and again, it biases the next person that's coming in to hear from them. And the research now is looking at, like I said, stigmatizing language. So it's language that can belittle or undermine their credibility as well. And some of the things we do about pain, we might say patient states or claims 10 out of 10 pain, but is talking on the phone the whole time. So I'll often ask, why did you ask them a pain score if you were not going to believe it at all? Only the person, the patient themselves, can tell you how much pain they're in. And there's plenty of research to show that we are poor judges of someone else's pain from the outside. And there are different cultural expressions that come with pain as well. So we shouldn't judge. Just ask the question. If you need to put in objective findings, put in something that doesn't put that together and undermine their credibility. It's causing a lot of issues with patients too, because they read their charts now.
Yeah.
And that's something that's relatively new. And we were not given instructions as providers on how to write in the medical record for patients to read it. But they're doing research now that shows that a lot of this language and the things that we use all the time are causing a lot of anger and distrust and perception of bias and discrimination with patients.
Yeah, it's true. So any advice for a nurse who has experienced trauma and is triggered when taking care of patients of her own?
I'm thinking that this happens a lot more often than we know about. It's a tough situation. I've seen my providers at my own institution have these experiences. I think a key thing here is if the nurse knows enough about her own trauma, his or her own trauma, and can recognize an acute stress response when it's happening, that individual should then step out of the environment for their own safety. not because they can't handle it. I want to emphasize here that this should never be put on that nurse that they're not capable or somehow that they've done something wrong. It's very unpredictable sometimes when those triggers happen, but we need to get them to safety. So if they have their own interventions that they use, they should be able to step away and think about whether it's grounding skills or getting fresh air, listening to music, whether they have their own self-care kits that I've talked about in my trainings. They fill a little baggie full of sensual sensual things like for touch, for smell, for taste. You put earbuds in there, go listen to a song, hold on to something that feels good, look at something that makes you smile, like 5 minutes even can help. They should also reach out to their staff leadership and let them know what is happening. So then that patient can get a new nurse to come in the meantime, because it's most likely not safe for that same person to come back in before they feel ready to do that. Now, sometimes the person who's having the acute stress response has no idea it's happening because they're in the heart of it. And that's where I think the leadership on the floor may need to step in and point it out to that nurse that something's not right here. I want, for your safety, I want to pull you out. And again, emphasizing that it's not punitive. It's for their psychological safety. Because if adversarial care is building, it's not good for anybody. So getting them to a safe space, pulling them aside, readjusting your assignments, and then taking care of that individual. But I also think it's important to, everyone should be preparing for these things, have partnerships, have some collaborations, maybe with your mental health folks at your hospital. Can you build in a safety net for your providers? If someone needs those few minutes, they should be able to step away. But that takes planning, and that means having the right amount of staff, and that's usually money. That's part of that as well. But that's what they're recommending now, is allowing for mental health days, allowing for breaks during the day, as well as encouraging all the standards, which I think most wellness programs do, like good nutrition, sleep hygiene. Hard to do when you're a night nurse, right? That's very challenging. Thinking about exercise, mindfulness things, and then if you need your own mental health support. But that's what I would suggest, is really helping them identify when it's happening, like just as you would for a patient. Whoa, I think that's my staff is being triggered, and to think about pulling them out. I've had staff members who, given the circumstances, couldn't go into the operating room right away. Like they're coming off of their own maternity leave. And we built in plans for them to say, why don't the first week you talk to your supervisor? They are right there going to watch you, have somebody else on staff that can take over if you can't do that day. And then you slowly work them back into reentry into their workspace. Because it's very challenging.
I like how you put that it's for their own safety, and using those words of like the psychological safety and being comfortable with that. So it's not that, your supervisor comes in and pulled you out of a situation because you can't handle it. It's because it's not safe for you. And I really like how you put it into those words. And I've heard you talk before about a trauma-informed organization. So we were just discussing, beyond the individual nurse, speaking to like nurse leaders, hospital administrators, you talked a little bit about things that they could do, but what other things would it take to be a trauma-informed organization?
Well,
it's a lot. I know.
It is, but it is the goal, right? Yeah. Not an easy
thing. Some of them might be listening today, so I'd like them to hear it from you, what it would take.
Well, it's going to take time. It's going to take buy-in from those up in leadership. It takes money to train, right? But really, to think about having only your workforce trained in the clinical trauma-informed care applications, meaning from providers to patients or providers to themselves, understanding their own traumas. It cannot happen alone. It has to happen, to be truly effective, it has to happen in parallel with the organizational trauma-informed care development. And there are some that are out there that are trying this. And now our state of Pennsylvania, the whole state is trying to build these levels of organizational trauma awareness and then moving through that continuum. But they have some key principles to help guide people in these organizations. I'm going to read some of them to you. So leading and communicating about the transformation process. So it has to be a big overview and you have to involve everybody in it. We want to engage patients in the organizational development. Like we're learning, we have to listen to patients. I was one too, in order to understand what they need. Right? What do they need from us? And we're talking about not just from a nurse to a patient level, for example, but what kind of signage do you put on the doors? Are your hallways well lit? We don't want to make it scary for them. Is it welcoming to all people? Like even on our units, it says woman and baby, but we've had our transgender individuals come through. So thinking through, is there signage that could be more welcoming to people? Are your offices set up where people don't feel like they have to take their clothes off immediately when they walk in? Is there a space to allow them to stay in their own clothes? For example, like those are some of the structural things, as well as hearing from patients. What do they need? Training clinical as well as non-clinical members of the team. So everybody from the person who is doing the outstanding work at cleaning our spaces to those that are on the phone talking to patients the night before they come in for their cesarean deliveries. Like everybody needs to be trained in some basic practices. Creating the safe environments. What does that look like? From a physical standpoint to the psychological standpoint. If all of your patients have to sit far away from the door and they can't get out, it could be scary. Do we need to rearrange? Are there chairs in all of your rooms? I think at my training, Jennifer, you realize sit down, right? It's a big thing.
Yeah.
Sit and talk to your patients.
We call it commit to sit.
Oh, I like that. Yeah, commit to sit. We want to, as a system, be looking out for the staff. So preventing that vicarious or secondary trauma with our staff members. And there is some trauma that may not be prevented. Major obstetric hemorrhage, for example, a death or loss of a child. You might be involved in something like that. But what do we do for those staff members after the fact is equally as important. So putting all of that into place. And then hiring a trauma-informed workforce. Yeah. That's a dream, because it's going to take a bit to get everyone trained in what they need to do. But those are some basic principles, but then it also means you might have to change your policies and your protocols. And that means more meetings. If you've ever been on the policy committee meeting, that's a lot. You might have to update your manuals. You might have to rearrange or reallocate funding. Those are the things at the system levels that need to be thought through, but starts with priority. Can we convince the leadership that this is important enough to make this kind of a change? And honestly, I think with our numbers of maternal mortality, because now we know that mental health and trauma-related conditions are the number one cause of death in our country, we're going to need mental health and trauma-focused types of practices and interventions to handle that. When we knew it was the leading cause was hemorrhage or hypertensive crises, what did? We dug in. We did research. We found out, okay, what are the best things we're doing? We got these bundles. We established that. We need to do the same thing for mental health, right? So there's a push. Plus, I mean, we have plenty of morbidity that comes from unresolved traumatic stress in pregnancy as well as labor and delivery. I mean, just some examples. We know that people who have birth trauma often go on to be very angry with us. They don't like us anymore. So they might not come back for postpartum care where we could look at their incisions, make sure they're not developing sepsis or other things that could contribute to maternal mortality. They don't come back for prenatal care next time. And then we judge them typically. Oh, no prenatal care. They probably don't care. Right? It happens. But maybe it's from the trauma. Some people dissociate after their trauma and they have to grieve the loss of the childbirth experience. And so when that happens, they develop mental health symptoms like depression. We know that breastfeeding success is lower, bonding success is lower after a traumatic birth. And when there's no bonding, parenting skills, parenting styles could be more negative. And then we see increased risk for psychiatric behavioral issues in the children later. I hear stories all the time about disrupted relationships, sexual dysfunction, and the family unit crumbles sometimes after a traumatic birth. And the more I read, the more I keep seeing it. People, they have to experience the birth trauma, guess what? Every year, same day as the child's birthday. I hadn't thought about that very much until a patient sent me an article and I went, yes, that's another consequence of a traumatic birth. So all of this is reason, and I could keep going, but a lot of this is the push for why do we need it? Well, we need it because trauma is just everywhere. It's pervasive. And if we have any hopes of like really reversing some of these trends, we need something different. So,
and I think another important thing is that trauma is very personal because what I think is a trauma might not be what somebody else thinks is a trauma. So I had a patient whose same story. It was a year coming up to the baby's birthday and everybody was excited. It's birthday time. And she's like, yeah, a year ago I was being induced for labor. A year ago, I remember this. And everybody didn't think that she had a trauma, but it was for her. And I think that is something I think people really need to be aware of, that trauma is not, it's personal. Like there's no way, even though for us as providers who came out with a healthy baby, everything seems fine to us. You had a traumatic event. And I think sometimes it's not recognized. So I'm hoping, so thank you for giving your 2 cents. It's just my 2 cents I had to add in.
No, it's a really good point, Jennifer, that it is in the eyes of the beholder only. And that's the definition of trauma. It's only that person's experience. We speak of complications a lot, right? Mm-hmm. Complications do not equate to trauma.
Yeah.
Right? So, and I've had patients who've had complications that we could pull off of the chart, ICD-10 codes. So you say, oh, this person had massive hemorrhage, but they felt supported. They felt safe. They were with their significant other. At no time did they feel abandoned. So they had a major hemorrhage, but they didn't develop PTS or post-traumatic stress symptoms. Now the flip is true too. Like you just said, you can have trauma without noticeable complications, meaning for us as providers, we say, physically, you left the hospital. You should be happy. There's the classic. You should be happy. You had a healthy baby. Or aren't you so grateful? You know, you're walking out of here. Well, sure, they can be grateful and happy that they have a healthy baby. That doesn't mean it wasn't traumatic. And you bring up a really good point too, in that society, family, friends, they don't always get it. And they tend to triage that person's emotional experience. And it's hard. I tell people all the time when I work with them and they're coming up on the anniversary, we talk about expectations. Plan for emotional roller coaster. Plan for this for the day. What are you going to be doing? Allow yourself the moments to be sad, angry, frustrated. You don't know how they're going to react. So I think letting them know that it's normal and it's okay, right? To feel these things is appropriate.
Bria, I think the next question is yours.
Okay, Dr. Vogel, you're schooling us today. And so, but I do have one last question for our listeners and the work that they're doing. Do you have a career hack that you would like to share?
Yes. 1, self-compassion, right? we all make mistakes. We all make mistakes. Mine started with the grievance. This whole journey started with what I consider to be something I did wrong. But if you can just take a moment and try to learn from it, you never know where that's going to take you. Right? We all strive to do the best we can. And sometimes we don't have the education. We don't understand something and we make mistakes. But really, we're all human. Just self-compassion. That's number one. The second thing that I think I would tell people is be curious. Right? Really, that is, to me, one of the most important things is just allow yourself some curiosity. Something doesn't seem quite right. Trust that gut instinct. There's probably more to what you're seeing than you know. There's something beneath the surface. And I really like to say that, because I hear this word all the time, this person's being irrational, and that grates at me, that word. But not all irrational behavior is irrational when you understand it in the proper context. So I'll leave you with that, because there's so much behind that curtain. If we just give it a moment to understand our people, the care is going to be so much better.
Oh, Dr. Vogel, thank you so much. I definitely feel like I was in the classroom and learned a lot. I know the listeners are going to get a lot from this today. This was an important conversation to have. Mm-hmm. I think that you have shared your journey. Other people can look back and think about their journey and say, I've made mistakes too. And take what you shared with us today and say, I'm ready to learn. I'm ready to do something different. And so Jennifer and I are just so grateful in here today. And we can all take this charge to better care for the people that are giving birth that we're responsible for. So thank you. If you'd like to listen to this episode again, you can go to awhon.org/podcast. You can read Dr. Vogel's full bio and download several of these resources that she shared with us today. If you'd like to watch the video, you can go to our YouTube channel. And so we want to thank our listeners, Jennifer and I. We want to show our appreciation for your time, because you've supported us through our relaunch. And we'd be delighted if you share how much you enjoy this podcast with a colleague or with a friend. You can subscribe on Apple Podcasts, on SoundCloud, or on Spotify, because you don't want to miss any of our upcoming episodes. So thank you all again. Very much a special thank to Dr. Vogel and to you, Jennifer. Everyone, take care and be safe. Until next time.